A Better You podcast is hosted by myself, Dr. Clifford Yun, physical therapist. We'll be talking about techniques to improve your mental and physical health. The ideas and topics discussed are based upon the experiences and research of myself and my guests. They do not replace the personal consultation of a trained clinician. If you or someone you know is having a mental or physical health problem, you should consult an appropriately certified clinician. Welcome, guys, to this week's A Better You podcast. This week, we're doing something a little bit different. It's not just me talking this time. I'm actually going to be interviewing doctor, and this is our first guest for the episode. Thank you, doctor, for visiting us. This is Dr. Theresa I'm going to screw it up again. Pazionis.
Pazionis. Very phonetic, just stand. Yeah, Theresa Pazionis.
Pazionis. All right, Dr. Theresa Pazionis. And I'm not going to try to butcher her profession too, as well as I butchered her name. So let's go and let's have her talk about herself and specifically her field and her field of expertise.
Okay, good morning, everyone. Hi. So I'm Dr. Theresa Pazionis. I'm a spine surgeon and orthopedic oncologist at Temple University Hospital. So I'm located in Philadelphia as well as in the Fox Chase area at Fox Chase Cancer Center. And my primary area of focus is adult spinal degenerative disease, as well as deformity correction, as well as oncologic spine surgery and orthopedic oncology in general. So in my patients that I'll see are, everyone from patients coming in with back pain who, need assessments and some physical therapy who ultimately don't need surgery, to patients who come in with scoliotic curves. We're talking, people who are kind of bent over to the side when they walk or bent forward, something we call chin on chest deformity, and who would like that addressed surgically so they can get back to living their life in a more comfortable way. Prior to being at Temple, I trained at Hospital for Special Surgery in New York and Memorial Sloan Kettering Cancer Center. And prior to that, I'm actually Canadian originally and immigrated to this country 7 years ago.
Oh, wow. Okay. Yeah. All right. That's a good story. First, originally I thought you were just from New York. I was like, oh no, she's Canadian. She's secretly Canadian. People, no,
secretly Canadian. I still like the syrup. I'm a big connoisseur of the
syrup. Well, I think the audience can understand why I wanted you on this podcast from my specialty as a Schroth PT, and also I like that. Here's the reality that as clinicians that yes, I'm a Schroth PT, but I do PT. I'm still a physical therapist, and just as that, you have so much of these. You have a lot of this focus. You have the cancer center, and then you have the all spine trauma area. But you can see that you are at the end of the day treating the person that comes in for you because of strictly pain. People are here for back pain, and that's what I like the parallel of the clinical field, and particularly the relationship between my field and your field.
Mm-hmm. And it's so good to meet someone who does adult Schroth physical therapy, because oftentimes I do try and prescribe it to patients who come in with a spinal deformity who don't want surgery, and that's okay, but who need to be doing something proactive with their physical therapy like Schroth. So it's great to have someone who accepts adult patients in the area.
Great, I appreciate it. All right, so I want to go through the laundry list of things that I want to talk to you. I could talk to you forever. Honestly, I probably could, but I'm going to try to focus on the big touch points that I hear most often. But before I get into that, I really want to talk about the reality of that we are a year from COVID starting, officially starting, and as far as in the minds of everyone. And I know in the health field as a doctor, and I can imagine for the rest of the hospital too. Dealing with the mental part of all this, and as a part of this podcast, the mental health. So can you talk about how either you've noticed how the hospital, as your colleagues, or even specifically yourself, has dealt with the mental struggles of the past year, and how do you keep that health up?
Yeah, I mean, it's challenging. I think everyone's had unique challenges with COVID. Obviously, from a healthcare perspective, you are in the middle of the pandemic, and you're seeing these very sick patients and dealing with a lot of the emotional fallout that happens from that. I mean, I can honestly only say thank you to my colleagues who primarily support the ICU and the cardiorespiratory or run the ECMO machines and things like this, and the ER physicians, because they really are the first responders to COVID. So, as a surgeon, you volunteer on the COVID ward and you do your week or so, but you're really not, like the physicians, the nurses, the sanitation staff, everyone who's, been doing that, just thank you. And it's gotten better. since we've had the vaccine, people have been, good with social distancing. And I think overall, the situation that we're in today is very different than the situation that we were in a year ago with the pandemic. But it's also been tough for patients to access care, I think. So formerly you could call up and make an appointment and you would come in. Now you might require a COVID test, to get a procedure. And it just makes it's an extra level of complexity that's already added onto patients who, are in pain and don't really want to deal with that to begin with, right? So it's definitely difficult. Currently, I think what's been really good about Temple is that we've done a really good job of kind of sequestering COVID away from non-COVID patients. So we've the Boyer Pavilion of our hospital, for example, now is all COVID wards, okay? Or, they haven't really opened it up because we still have that availability. And all of our non-COVID patients are over in the other wing of the hospital. So it is really two separate buildings. So that's nice, and that gives patients an added level of security. I think dealing with it mentally, I mean, as a healthcare provider, again, different challenges. Oftentimes, I actually feel really fortunate to be able to go into work, both because I really love my job and I like coming to work. But my best friend, for example, is an administrator at the City University of New York. And she has been working from home for a year, doing obviously very relevant work in terms of like ongoing, virtual classes and things like that. But to not have that colleague interaction, I can only imagine how hard that is, right? So as, essential service workers, healthcare providers, anyone who works in the food industry, things like this, we are in a way fortunate to have to go to work to kind of keep up our social interactions in a way. So I think there's a lot of points to it, but really anything that you can do outside of the workplace that will kind of keep you sane. So like I go hiking a lot, finding outdoor activities. A lot of my friends got into baking. So I have a friend who now she's a plastic surgeon. She now makes cakes, like she makes awesome cakes. So finding something that kind of speaks to you, I think is really important.
Yeah, absolutely. I definitely believe in that.
Yeah.
Totally side note. I remember when I was doing my clinical rotations back in school, and there was a retired, I think it was a plastic surgeon too.
Yeah.
And he retired and just started making cheesecakes. And then he started making a cheesecake business. So
no, and it's totally legit, right? So every time I see Janelle's Instagram posts, by the way, follow her, Janelle Wagner Egan. She's awesome. She makes phenomenal cakes.
It sounds good. I got a lot of my audience is from New York, so they're definitely going to be reaching out to her. That's for
absolutely.
Sure. Okay, so I want to switch gears and kind of focus a little bit more on the concepts that are kind of really a huge topic that's really coming up a lot more in the kind of Facebook groups that I'm part of because of scoliosis. But I think in general, we want to talk about pain and pain management.
Sure.
As a spine trauma surgeon, and also for someone who sees scoliosis people, pain is a huge subject matter. Mm-hmm. And I want to first start talking about how, first the initial concept of when we get diagnosed with pain, and then we'll get an X-ray, see where things are coming from. And what people get caught up on a lot is that here's my X-ray, my spine looks like this. How come I don't have any pain? Here's my spine, it looks like this. How come I have pain? What's the understanding of an X-ray that shows any level of scoliosis or any level of arthritis, and why this person has pain and why this person doesn't? Like, can you explain that for me?
So I think both, okay, I'll try and explain it, as I understand it and how I present it to my patients, but also I think it's very important to understand that pain is not something that is 100% understood for everyone, right? So you might have one patient with a horrific spinal deformity that they're just completely unbothered by and just living their lives. So a lot of pain is the physical pain, but also how you psychologically interpret that. And there's many people who are able to live with their pain, and it actually becomes less of an integral part of their life. And there's some patients who I have who come in who really identify with their pain, and it really overwhelms everything else that they do. And I think that a lot of this depends on how your pain was treated in the past. Did you feel that your pain was addressed? A lot of patients come in, and unfortunately, due to health disparities, you look at people whose pain just hasn't been addressed by healthcare providers. Okay, we have a lot of minority populations, BIPOC, predominantly African American people, who unfortunately, and there's publications to back this up, don't have their pain addressed as adequately as their counterparts, which is really unfortunate. And it's something that at Temple University, we really are working to combat. So everyone who comes in will get a pain assessment. Oftentimes you're referred to pain management through our universal back pain program, and your pain is going to get addressed. Okay, it's real and you're experiencing it. That being said, the answer to everybody's pain is not just pain pills. I think it's really important that you take a multimodal approach to it and you say, hey, listen, there are real side effects, and the opioid epidemic is something that unfortunately, especially in North Philadelphia, being adjacent to Kensington and things, we see a lot of patients who have tried, purchasing their medications from the streets and things like this because that's what's available. And we really would like to help patients avoid that because it does run into a couple of issues. Number one, it doesn't actually help the pain. You can actually get opioid hypersensitivity syndrome, where the more opioid you take, the worse your pain will actually be perceived, and you need an escalating higher and higher dose. Other medications like meloxicam, cyclobenzaprine, topical medications. So I use a lot of lidoderm patches and Voltaren gel in my practice, and that can be used actually in concert with a good physical therapist who will also, apply heat, apply TENS, apply electrostimulation to kind of try and address that local pain. And the goal is to have the patients be on the minimum pain medication that they need with a maximum pain relief. And oftentimes, that involves a multimodal approach to pain. It's not just one pain pill. And unfortunately, what we've seen is a lot of, mostly kind of peripheral physicians' offices in the past, including some that would have gotten shut down for narcotic, by the FDA for narcotic abuse, is you can't just give people pain pills and not follow up with them. It's just not responsible. It's not good medicine. And it's ultimately really not good patient care, because you want to actually treat your patients, not just prescribe something for them and say, okay, figure it out. So what I do in my practice is I'll talk to the patients. I'll say, okay, is this pain that's related to activity? Is it pain that's related to rest? Is it pain that's all the time? Is it pain that's just in your back, or is it all over your body? Does it get better if your posture corrects itself? So really taking a quality pain history and also talking to that patient about factors that might make them pain hypersensitive is really important. So in my practice, we do work with the pain management group really closely, and the physical therapy group really closely. And sometimes, honestly, narcotics are appropriate. Like I prescribe, the occasional Percocet for, there's this lady, she's, obviously not giving away any HIPAA incompliant information, but she's elderly. She takes one Percocet a night. It helps her do her stuff. She doesn't abuse it. Okay, that's fine. And that's a reasonable medication for that lady to be on, versus somebody who's taking the Percocet and it's just not working for them. Well, it means that maybe that medication is not working, and we need to find a better way to address that patient's pain and to treat that patient appropriately.
Right. So it's about really, you really touched upon it. It's about communication there, and taking the time for that communication. Too often we hear these stories where there's really, there's an excess of, okay, I didn't use these drugs before, but they're sitting in my medicine cabinet, and you realize that you've given this person, drugs over months. That now they have a stockpile, and then they may not have that issue initially, but then they're running to it later on. So that communication, that education of what is necessary, and talking about how to understand pain for that patient, how the patient can begin to learn what that, how to look at pain, how to feel pain, how to really work with it.
It's communication and it's health equity, right? So if you look at it, you have to make sure that patients are getting equitable treatment. And if they haven't gotten equitable treatment before, understanding the experiences that those patients have been through, listening to your patients, talking to them and be like, okay, let's talk about your perception of pain and what your perception of who's treated your pain before. But because a lot of times people be very nervous to come into the doctor's office for fear of being judged for their pain, which is awful. And it's something that we really have to work to combat as a community, as a medical community.
That's actually a good point that I want to talk about. But before I forget, I do want to talk about the big thing that everyone talks about now. And often I hear the questions of, what about medical marijuana, or even just CBD itself? How do I know where to get it? Is it even worth it? What is your perspective on that, on like the current research in your profession?
So research, and from my background as, having initially practiced medicine in Canada, legalize it. Okay. It's something that the reason that the medical marijuana has not been legalized in this country is predominantly political. Okay. It is a medication that works. And if you look at, in Canada, I remember when I was a medical student back in, 2004, patients were on Marinol. And for cancer patients especially, which is where we have the largest body of literature, this is increasing patients' appetite, which oftentimes can decrease if you're in pain, you don't want to eat. Okay. And then you end up with sarcopenia, which is wasting of the muscles, surrounding not being able to eat properly. People's pains are relieved. There's less mental fog side effects than you'll get with traditional opioid therapy. And oftentimes, if you look at, even let's just look at, marijuana crime versus opioid crime. Okay. I know that that's a concern that a lot of lawmakers will bring up. You're like, realistically, nobody's getting high on marijuana and doing anything crazy. It's, you sit at home and, as you do, right? But predominantly, if you look at why it was demonized back in the 1960s, and Temple put on a really great course about this, it was predominantly a racial thing, which is, and I think that in our community, we have to really work to combat that. And if we're not legalizing a medication that is helping a large number of people, really we have to think about why. We have good medical research to say that medical marijuana does work for cancer-related pain. It does work for appetite. It does work for spine-related pain, musculoskeletal pain. And I'm actually conducting a research study right now to just ask patients unofficially off the record, hey, listen, have you tried marijuana? Predominantly why? Okay. People are using marijuana in our community and in the Philadelphia community and the New York community for their pain. They're oftentimes getting it from their kids. Okay. Which is fair enough. But if this is a medication that legitimately is helping this many people, why haven't we done more to legalize it? And I think we are doing those things. In New York, there's now been, in March 24th, I believe they actually just came out with new legislation. It's now legal for medical and recreational use in New Jersey. But the barrier that a lot of our patients run into is to get a medical marijuana card, it's still about $200. And a lot of people will not have $200, quite understandably. So improving accessibility, I think not having to have a cards to get medication that you need is probably important. And just having it regulated by, the medical profession or by, pharmacists or PharmDs, as opposed to the government is probably something that we really should be pushing towards and lobbying for as a profession. So to improve our patient care, because it's not only a medication that's helpful, it's a medication that our patients are already using and it's working well for them.
And and in relation to the incredibly accessible CBD, which is almost everywhere, what's your opinions on that?
I think it works well. I mean, I've got patients that use it. It's a mixed bag, really. I think it does work well for relaxation. So from what I've kind of gleaned from my patients, for it's actually a similar effect to cyclobenzaprine for some people. Now the good thing is CBD can also be hemp derived, so it's completely THC free. THC is the marijuana component of it, really. Where that's the classic thing where people will be like, okay, well, this will make you high. It won't, practically, if you're having a controlled tablet dosage dispensed by a pharmacist. But the CBD is something that's available over the counter. It can be hemp derived or cannabis derived. Okay. And some people like it, some people don't, but it's legal and it has fairly, minimal side effects, and you can get it without a card. So there's not really a whole lot of downside in trying it. And I see a lot of patients who already have tried it, suggested by oftentimes their children.
Right. I think that's the big misunderstanding, that CBD is going to get you high, or
it's not. No, it's really not. Who have had cancer, okay, who do take it, in Canada, and it wasn't something that people stay on long term. You might stay on it during chemotherapy, okay, and it'll help with the nausea and the side effects and things like this. So this is something that I really think we should be doing more work on, federally legalizing.
Absolutely, I agree. All right, so then let's go back to that other topic of communication. We'll go from 2 points of view. From the medical point of view, we often, from the rehab PT side, I've often had discussions with other clinicians feeling like we're not getting a clear communication with the doctors. Is there something that you feel that can improve our conversation between the rehab team and the doctor team?
Yeah, I mean, I think just call me. I mean, and certainly you do. I mean, you have my cell phone number. I have a good relationship with Fortaleza Physical Therapy, which predominantly serves our Hispanic community. They're Spanish-speaking physical therapists. It's great. So they'll call. And I think the key thing is just talking to people and interfacing with them. So, in my clinic, our temple PTs are right next to us. And so I work with Paul and Tom quite a lot. I'll just walk back, say hi, text them, we will hang out and grab a coffee sometime. But I think the key thing is just recognizing that we're all colleagues and that we work together. And, if I don't do my job properly, you can't do your job properly. If you don't do your job properly, I can't do my job properly. So it really is something where, as long as you get along with the people that you work with, you like them, and you actually take an effort to treat other people like people, I think that there's good communication. And unfortunately, I have heard, it's honestly less so. I really like everybody I work with, so I'm probably the worst example of this. You obviously work with other physicians who sometimes you're just like, physical therapy, figure it out. And you're like, no, like, talk to me. And if the script is just a fast script, which I'll sometimes be guilty of writing, I'll just be like, PT, assess, and treat. Just call me up. You're like, hey, Mr. So-and-so's in the office. Be like, oh yeah, here's what he had. Okay. Or oftentimes I'll print out the patient's x-rays and be like, no, your back is fused. You literally can't do this. Don't do this, And so as long as, what procedure they've had, maybe you have a picture of the x-rays, you're going to be able to make that professional judgment. The other thing that I really get to is actually trusting people's professional judgment. So if you think that somebody has, progressed as far as they're going to progress on trough, okay, and they're still uncomfortable and they still have a deformity where they're not able to walk straight, okay, well then talking to our patients and sort of saying, listen, we've sort of maxed out on PT, you might want to go back and discuss surgery. Or I'll say, listen, I really don't think you need surgery. Maybe let's continue some PT. And as long as everyone's on the same page, I think the patients are going to be getting the information that they need to make the best health decision for themselves.
Right, right. So then this goes over to the next level. Then the patients, I think this is a common thing too, that patients almost feel too nervous in the patient seat, white coat syndrome. And often I'll arrive at a visit and they'll spew 10 billion questions toward me. I say, well, why didn't you ask the doctor about this? And what can you tell the patients that, like, what do they need to be thinking about when they get to a doctor visit and they have their questions?
So just ask the questions. And honestly, if your doctor is not answering the questions, then it may be you want to talk to a different doctor. Because I would say that, I've obviously gone to doctors, you've gone to doctors, we all have, right? And if you don't feel that your questions are being adequately addressed or you're not being adequately heard, well, okay, if it's an emergency issue, you might not really have too much of a shopping option. But if it's an elective surgery, you really want to feel comfortable and make sure that your questions have been answered and you understand why you need a surgery or why you don't need a surgery, right? The other thing is, think of going to the office as an information gathering experience, not just, I need surgery, I'm going to a surgeon. So patients who come into my office, I'd say if I have 40 patients in the clinic in the day, maybe about 25% of those are actually signing a surgical consent, okay? Maximum. Some people are coming in because someone told me I need surgery. I'm not really sure, what does a surgery sound like? And oftentimes I'll suggest that you write down some questions and come back with a family member, talk to your family about it, talk to your friends. The other really important thing that I think is important is that if a patient, and a lot of this just goes to interpersonal skills, if a patient seems really apprehensive coming into the office, ask the question. And this is more targeted at other healthcare providers who might be listening to this podcast. Say like, hey, what's gone on in your past? Okay. That because you seem kind of nervous. How can I help you with that? What's happened? And I've gotten, people will tell you things, right? And it's really legitimate. Like, some people have had really awful experiences with the medical profession. And it's something that, well, especially spine surgeons, it's something that we really have to work to combat as a specialty, doing responsible spine surgery. Doing spine surgery that's going to help people versus, loose indication spine surgery. So, your indications have to be good. And you have to understand that patients may have come from a perspective of their family member didn't have a good outcome with spine surgery, or they have somebody in their church group who had spine surgery and now can't walk. And, but you never really know what people have been through unless you ask them, and so I think asking your patients their perspective versus just telling them is very important.
Great, great. At the end of the day, I think the problem the problem may be that between even clinicians as well as patients is that we are all just human, and if you
Right.
bother to say hello, someone generally is going to say hello back, and if they're not, let's just have a conversation. We're all just trying to, we're trying, as professions, we're there for a reason, and
Mhm.
if you ask us a question, we're going to answer that question.
Yeah.
there's a stigmatism about rushing appointments and the intensity of
Yeah.
an office. And
So my main complaint that I get in my office is, oh, I had to wait a long time. I'm like, yeah, sorry. I mean, I try to, so we have my office clinic flow is we have Brian Neubauer, who's our PA, who's awesome. And so basically you'll get the first intake assessment is going to be Brian, or our resident right now is Josh. And then I'll basically go to room. And what that helps is it'll kind of help them kind of get the story, get the x-rays pulled up, all this sort of stuff. And then I'll be able to really like spend time and kind of talk to people about, hey, what are your questions? Like what's going on? And sometimes it takes a while longer. And unfortunately, we are working in a city hospital. We're not a private practice. We're, federally funded, and we take all comers. We take Medicare, Medicaid, health district, and people who have other insurances, so we don't have 5 patients a day. We've got 40, but we want to take our time with everybody. So if your appointment's delayed, no problem. Go down and grab a coffee. Okay, I will get to you, and you will have, your 45 minutes or however long you need to kind of talk about things, right? But just sort of, bearing with us. And I always appreciate when patients, understand that I will get to you, I promise. But if you're waiting a little bit, I'm really sorry about it. I'm just, trying to give everyone that really good level of care.
Yeah, that's just to realize that during that time with you, that it's not that not that you don't want to see them or you don't want to spend time, like there's, and those people that are seeing before they see you are not like they're not.
Yeah, no, it's more just a paperwork thing, because if you can imagine, I mean, I'd rather spend my time actually interfacing with patients, talking to them, doing all that kind of stuff. There's also a note that goes along with that, which a lot of people will need. So for example, if they've been involved in an accident, or they need that note for like their caseworker or something. That's a lot of paperwork. So like, just so we split it up 3 ways versus me going home and writing 40 notes and crying over them. Like, I love that Brian and Josh help. So please do speak to Brian and Josh. It helps everyone.
Yeah.
You fill out a ton of paperwork too. It's
Oh yeah. And that's part of the thing too. Yeah. So that people understand that there's a reason for the process, but it's not that we're not.
No, it's more just that we're all people, and we're all just sort of trying to give everybody care, and the paperwork. Yeah. Oh my goodness. So
all right. What else want to talk? Oh yes. So let's talk about on scoliosis end, and
yes.
And another common question I have is bracing, and
Sure.
What constitutes bracing for? And we can go into end as far as the adolescents. That's pretty much out there as far as people know. But I think adults struggle with this more. Like, when is bracing even a thing for adults, and when isn't it? And when is it?
So I'm of mixed mind on braces, and I think that there's patients that if it looks like it's going to be a good thing for bracing, then you brace it. So adolescent scoliosis, okay, good evidence for bracing when it's a pre-surgical curve if they're still skeletally immature, okay, and that's something that's pretty well agreed upon. You have a lot of adolescents who do come in with a brace for the scoliosis to prevent it from progressing, and they do quite well, okay, and that depends on curve magnitude and patient characteristics, things like this. For adults, if I operate on somebody, they will get a brace post-operatively to kind of help them, heal and feel supported as they heal. Okay, so that's the operative patients. And then you have people who are sort of in between. So you're an adult, you've got spinal deformity, or you've got a spondylolisthesis. Okay, should I use a brace? And that's a question I get a lot. So number one is, if you depend on a brace, okay, and if the brace is a crutch for you, you'll eventually weaken your core muscles. Okay. Your paraspinal musculature to the point where you become dependent on that brace, which should not be the goal. The goal should be to kind of have you brace free. If you become dependent on the brace, well, at that point, we're really more talking about maybe you need an internal brace or a spinal correction surgery. Okay, so you're not having to strap on that external brace every day. Okay. There are some people who can't have surgery. Okay, and so we see a lot of patients who've got cancer, for example, who are, some of them are well enough to undergo surgery, others are not well enough to undergo surgery, and sometimes they may have a fracture or something like this that they need to rely on that brace. But for patients who just are general, adults, scoliosis, I do think, and there has been some evidence that there's a role for night bracing. And it's not every patient. And the key thing is it's healthy, active patients with good bone density, okay, who are also going to be participating wholeheartedly in a physical therapy program and strengthening those muscles, right? So, and the brace can be used more so If it's a flexible deformity, meaning when you take scoliosis x-rays, you can bend out your curve to some degree, okay? Or it's more of a postural curve where you really just need a gradual postural correction, okay? So I went to a symposium last year, and before this symposium, I was actually dead set against bracing for adults. I was like, well, you know, unless you're going to be operating, you don't need it. And then Tom Errico, who is formerly the chief at NYU, who does a ton of spinal deformity correction, and he's phenomenal. We had a really good discussion about the role for adult bracing. And Baron Launer as well at Mount Sinai, who does anterior deformity correction, you know. And so I thought about it, and I said, you know what? It's an emerging field in the literature, but if there is an adult, you know, sort of from 20, sort of on the younger physiologic end, right, more like a kid than not, to 40, okay, with a braceable body habitus, so meaning, you know, usually more on the lower BMI end of things, where you're going to get a really good contact brace. If you're sleeping at night, you're not going to be moving around that much, and there might be a role for nighttime bracing. So I've actually prescribed it for one patient after talking with a couple of my mentors about it, and you know, she seems to really like it. So it's not something I do a whole lot of in my practice, because usually more I'm dealing with like a rigid spinal deformity and in a patient who might not have a body habitus that's they don't want to wear a brace. A lot of people just don't want to do it. It's pretty uncomfortable. I've tried them on personally, and you know, it's something it's a discussion to be had with your patient. So if they're going to be compliant with it, if it's somewhat covered by their insurance, or they can afford to buy the brace, which can sometimes run about $200, $300, $400, $500 sometimes, sure, it's worth it to try.
Right.
Yeah.
Thank you. I think that's exactly what my audience needs to be able to hear and kind of decide on their own if that's the option for them.
Yeah.
I think, I guess that brings up the other point too, on decisions that these patients have to make ultimately, is that when it comes to surgery, you know, I think everyone battles with the idea of surgery. Surgery isn't taken lightly, you know. What is, at the end of the day, when it comes to pain and surgery, what do you think is the thing that the patient should really be weighing when they're trying to decide yes or no at the end of the day when they have pain?
Yeah. So I think it's not just pain, it's pain and disability when you're in a deformity algorithm, right? So my back hurts. Okay, well, my back hurts, your back hurts. It's okay. If you're able to live with your back pain and you don't have disability secondary to your back pain, then probably you don't need surgery. Okay. Even if you have no pain, I have patients who come in with a deformity like a chin on chest deformity, for example, which is where you're kind of see like this compared to this, right? If your horizontal gaze isn't maintained and you've got to pitch yourself back to look straight, even if you're not really in pain, that's really kind of annoying to have to live that way, right? So you might want that addressed. So I think what we'll ask patients is, do you want your pain addressed from the surgery? Or is it more of the disability and the deformity that you're running into? So really kind of understanding what the algorithm is. A lot of times, so fusions for back pain is something that I try not to do a whole lot of in my practice, because they don't work as well for pure back pain, okay? So the literature says it's about 60% of patients will have pain relief, and it depends why you're doing it. Now, that being said, you look at why we have that literature. Unfortunately, in the past, there was a lot of patients just having spine surgery because, well, my back hurts. Nobody's done a workup on me, but somebody fused my spine. That's not great, right? I think if you have a deformity, oftentimes it is pretty uncomfortable. And if you have bone-on-bone arthritis in your back, meaning that your discs, actually I have a spine model here. So these are discs, okay, right here. So if you've got your discs really worn away and your bones are rubbing on each other, okay, that's going to be pretty uncomfortable. And it's the same as having bone-on-bone arthritis in your knee. So I think part of it is also looking at really, why does your patient have pain? Is it back pain or is it leg pain? And managing the expectations. So oftentimes I'll tell my patients, listen, the literature says 60%, but you've got bone-on-bone arthritis here. And part of why we're doing the fusion is also you have a slip or a spondylolisthesis in your back, which is a good indication for back surgery. Okay, or if you have to decompress the back and you're afraid that they're going to become unstable because you've got to remove a facet joint, okay, something like that. Also a good indication for back surgery. The goal is to correct your deformity, okay, and improve your function, or to help the leg pain, or to correct the instability, and your back pain will probably get better. Okay. And I would say overall, the majority of patients, their back pain does get better. If it doesn't, I think that there's two factors that kind of play into back pain. There's the pain that's related to the gait malfunction and things like this that are inherent with deformity. Okay. There's the pain that's related to the arthritis, the facet arthritis and things like this, which should get dealt with by a fusion. Okay. And then there's also pain that's related to the nerves. So in some patients who get a deformity correction or a decompression infusion for an instability, for example, in their spine, if the surgery fails to completely resolve their pain, there is an option for something called a neurostimulator that I'll bring up with patients and talk to them about and say, hey, listen, if we've given you the best bone structure we can give you, and you're still uncomfortable, it may be a nerve damage problem. And as of now, there's actually not a surgery to address patients who have nerve damage from the compression or from the arthritis. But the neurostimulator actually does do a pretty good job of addressing that. And if that's something that's appropriate for that patient, then I'll bring that up. Okay.
That's great. Thank you. Thank you.
Yeah.
All right. So I don't want to eat up all your time because I know you're on call today.
I am. I'm
so,
I got the phone right here. So
yeah. So, it's been a lot of information. Again, I feel like we can do like a whole podcast series beyond this.
For sure. Yeah.
But yeah, why not? It's a whole nother conversation that we could have off camera. But let's make sure that that the public, the people who are listening and watching, are able to reach out to you. What's the best way for them to reach your office?
Sure. So the office is, so I would say there's two ways. Okay. So the phone number is 215-707-2111. With COVID, our phone lines have been a little bit, there's a phone tree and it gets a little bit interesting. If you need a consult, if you're interested in having back surgery or someone's told you that you need back surgery, you can also email me. I'm in the OR obviously a lot of the time, so it's not going to be like an immediate I'll get back to you, but I will get back to you. And it's Theresa, Theresa .Pazionis, Pazionis @tuhs.temple.edu, and that link is also going to be Cliff is going to put it in the comments. So feel free to email me, and I will get you set for an appointment. Okay.
Thank you very much, Doctor. This has been a fantastic conversation.
Yeah, absolutely. It's been great to do this.
Yeah, I feel like I've gained a lot of information here that I've been struggling to get that clear communication from my perspective to tell someone isn't the same from hearing it from a surgeon, because I feel that people at the end of the day, like, but the surgeon said this, but yeah, the surgeon's saying that you have options for your pain management,
right? And
that your function is very important.
Right.
Okay, so at the end of all this, we want to answer one question, and,
sure.
this relates to my second podcast, and it talked about habits, and we all have habits. So let's talk. I want to know if there's a habit that you're thinking of that you think that you can change to be something that can make you a better habit for you, and a better version of you.
Awesome. So my one thing, I recently started doing this, drinking water. Basically I go to the gym every day. I'm like a gym nut, and I always come in massively dehydrated. And I think part of that is, as a surgeon, you don't want to have to go to the bathroom in the middle of the OR. But actually some of my gym buddies got me onto drinking water. Before I would just drink a lot of coffee and I had some water. But I feel a lot better. Like, I feel like hydrated. So, and I would always kind of make fun of people who were well hydrated, just socially, just being like, you look well hydrated, good for you. But no, it's great. It's really good. You should drink water.
Thank you so much for that. It's life-changing. This amazing thing.
I know. And I was like, oh, I don't have time to drink water, but now I'm like, it works.
Yeah, go figure. It's one of those other things. That population out there, I among them, in our 30s ages, are realizing we don't move as well if we don't drink enough water. So
no, exactly. And I'm just like, and I remember I was like, I had a bad call week, and my friend came up to me and she's like, drink some water. I'm like, no, why did you say that? And then I started doing it. Now I'm actually like, oh, that's why everyone was telling me to drink water for like years.
I know. It takes a community.
Right.
All right, doctor, thank you so much for your
Yeah,
time.
thank you so much. You're
And
great.
we will definitely have this conversation soon again. Thank you.
Yes, for sure.
And until next time, everyone, we both hope that you continue to make a better version of you. Thank you.
Yeah.
If you have enjoyed this episode of A Better You podcast, please like and leave a review on Apple Podcasts, Spotify, and wherever you listen to your podcasts. I'd love to hear your thoughts and ideas for future episodes of A Better You. For more information about myself, Dr. Clifford Yun, and my services, head to cliffpt.com. That's CLIFFPT.com.